The agenda for this webinar is as follows. So we'll first introduce Ariadne Labs, and then we're going to go into detail about TeamBirth and research about TeamBirth, and then go into what TeamBirth will look like for your sites. And at the end of the session, we'll leave a good amount of time to address any questions and discuss next steps.
Thanks, Bea. So I'm Amber Wyseth, and I'm the director of the Delivery Decisions Initiative, which is a really long title for basically, I get to lead a program at Ariadne Labs that really focuses on designing research and advocacy for maternal health. So I'm going to spend a few minutes going over with you all what Ariadne is, so you understand where we come from organizationally, and then we'll dive right into TeamBirth. While I'm covering Ariadne Labs, if you don't mind locating your chat boxes and pull them up, we would love to know your name and where you're from. So specifically what hospital or organization you're from. If you are called in and you've got a group of people sitting with you, please do put everyone's names in so we know who is on this call with us today. So go ahead and go to the next slide. So Ariadne Labs is an organization that's in the Boston area. We are actually a joint center between Brigham and Women's and Harvard T.H. Chan School of Public Health. And we really focus on designing simple solutions that save lives and reduce suffering. So for our particular program, we do that really focused on maternal health. Ariadne Labs was originally started by Dr. Atul Gawande, and any of you who work in inpatient settings and have been in an operating room will probably be familiar with some of our work. So the surgical safety checklist, or the items you go over when you do a surgical pause, that was originally designed at Ariadne Labs in coordination with the World Health Organization. And again, it's a simple solution. It's a few items that you list off, but it helps teams to work better together. And in our research showed it saves lives and it reduces morbidities. So if you go to the next slide, this is just a snapshot. Don't worry, I'm not going to read it all to you, but this is just a snapshot of where Ariadne is doing work across the globe. So we do work extensively in the United States, which is where our program is very focused right now, but you can see a lot of the other programs are doing work outside of the United States, all across the globe. All right, if you go to the next one. So again, our team, we have this vision that every person can choose to grow their family with dignity. And I have the privilege of leading an amazing team. If you go to the next slide, you will see some of their pictures. So on the call with me today, Jonathan Walensky, who is our assistant director, and he really manages a lot of the operations for our work. And then you already saw Bea, and she is one of our research assistants. But you'll see a lot of these other faces as we get to work with you in the future. All right, next slide. Okay, so thank you guys for filling out the chat. I do see them coming in, so please keep going. If you haven't gotten your name in there, feel free to add it. So why do we do this work? Why are we talking to you today? Why are we working in Oklahoma? Well, here are some of the statistics that we're focused on. So on the left, you're looking at data that you hopefully are familiar with, that in the United States, we have the highest maternal mortality among all the developed countries. And the CDC just recently came out with our 2020 data. And unfortunately, but not surprising, maternal mortality worsened again. And I know we haven't looked at our 2021 data yet, but given all of the impacts of COVID, especially on people giving birth, I think it's likely that we're going to see another year of that statistic getting worse. And really over the past generation, we've seen this huge increase in maternal mortality. We've seen it in maternal morbidity, and we've also seen it in overutilization of healthcare, so specifically C-section rates. Now, when you look at some of the root causes of these failures or these sentinel events that come up, the Joint Commission actually publishes that 80 to 90% of them have a root in teamwork and communication. So what that means is when you have a mom that dies from maternal hemorrhage or postpartum hemorrhage, it's not usually that you didn't have the equipment or didn't have people or didn't have blood. It more often than not has a root cause failure in communication, where it didn't get escalated in time or the right people didn't communicate. So it's where we focus a lot of our work, is on how do we get teams to work better together and to communicate all across the team, including the patient. And if you look at these statistics on the right, it's really focused on experience. So we care not only about how your birth outcome turns out, but we care really deeply around your experience. We want every person who gives birth to feel respected, to feel like they're shown dignity, to have autonomy and a voice in their care. And so those are some of the statistics in recent research around the amount of women who feel like they have some sort of mistreatment when they go in to give birth. So this is our motivation. This is our impetus of why we designed TeamBirth and why we keep doing TeamBirth and why we're working with you all in Oklahoma to try to make birth better, not only for outcomes, but for every experience, for every person that gives birth to have a better experience. All right, let's go into the next slide. Okay, so what is TeamBirth? I've mentioned it a couple times. We're going to give you a high-level introduction to it, and we're not going to tell you all about TeamBirth because we don't have time, but hopefully at the end of, 10 minutes from now, you will have a basic understanding of how TeamBirth care is different than the current care. Now, when you're listening to us, you will hear things where you're like, I'm already doing that, or we're already doing that as a hospital. That's great. We love that because it makes implementation easier. But listen for the times, or think about the times you're not doing it for every patient, or you're not doing it every time, or you're not doing it with the patient, but you're doing it actually to a patient. So listen for those nuances. So let's go to the next slide. Okay, so the purpose of TeamBirth is it's meant, again, we focused on teamwork and communication. So the solution is really focused on empowering each member of the care team to share their expertise. So for patients, this is a different role. This is involving them in decision-making, involving them transparently in what is happening in their care, and expecting them to use their lived expertise. They know their body really well, and only they can report certain symptoms or experiences. And for providers, it encourages them to be on the same page and to communicate more effectively. And hopefully, for most providers, it should reduce actually some amount of the time or the redundancies in communication, because we're going to do it once really well together instead of all disjointed. So we go to the next slide. So the principles of TeamBirth, like how it was designed, is the first is on teamwork. So I've said team like a million times. You're going to keep hearing that. We really want to create an environment with TeamBirth where everyone feels safe to share their information and feels a part of the team. So that's crucial. But the other is simplicity. Like I said in the beginning, at Ariadne, we designed simple solutions. So we know that the healthcare world right now, and has been for several years, is very complex. We do not want to add a bunch of complexities to your already busy lives. So we believe TeamBirth is actually the most simple solution that we could create that will enable teams to work well together to see these improvements. So when I show you the board in just a couple minutes, you will get what I mean by simplistic. There's no artificial intelligence. There's nothing flashy about it. It is quite simple, but it does work. So if you go to the next slide. So TeamBirth in its core, so it's like most drilled down form, are two things. One is structured team huddles. So that is where you come together at specific times during labor and birth and postpartum to have a conversation with the care team. So let's say we're thinking about this patient may need a C-section. The TeamBirth huddle would be bringing that team together to talk about it. And there's certain conversational structures that need to take place, which you'll see in just a second. The other is that those huddles are then transparently put up onto what we call a shared planning board, which is basically just a fancy word for a dry erase board or a whiteboard, so that what you talked about, it actually stays visible and transparent in the room. So when the provider leaves or the midwife is not in the room, everybody still knows what the plan is and what's important to this patient. We do have specific ways that we implement TeamBirth, and we have such an honor and privilege to work so closely with your teams. Because this has been funded by the Department of Health and we have such great partners with the PQC, we're going to get to know your teams well, and we're going to walk you through the process, break it down into small little increments, and make this project really doable for you all. And we have a lot of experience working with teams, big hospitals, small hospitals, academic, rural, et cetera. So we will be partnering. We'll also partner on the measurement. Because if we're going to do an intervention that we think is going to make care better for people, we need to hear from them so that we know whether we are making it better for patients. And then what our historical research to date, which I will show you some of that data later on, has been that we'll see an improvement in outcomes and experience. So Isaiah is going to go a little bit more detail into what a huddle is, like what we cover when we do those huddles and what the board looks like.
Yes, so core to TeamBirth are the huddles. So these huddles involve the direct care team and does involve the person in labor and their support person or people. And some huddles will, especially if with physicians, will involve a member of the care team on speakerphone if they can't be in person. So during those huddles, you'll want to discuss your patient's preferences, what the care plan is for mom, the baby, and labor progress, as well as expectations for the next huddle. For example, we'll huddle in approximately 2 to 3 hours to discuss X, Y, or Z. And then key for understanding the TeamBirth huddles is understanding when these huddles take place. So they're really taking place at admission or at other key decision points or changes in the plan of care, as well as if anyone from the care team requests a huddle. And the why for these huddles is really to give the patient the opportunity to participate in shared decision-making, to provide the patient with agency, information, and autonomy during their birth experience. So I'll go into a visual to see how these team huddles work. So the core TeamBirth components are the structured TeamBirth huddles, which are really depicted in this image pretty well. And then the shared planning board, which you see on the right, which we'll delve into in the next slide. But the huddles and the planning board together create this really joint shared decision-making tool.
Isaiah, can I interrupt you really quick?
Yes.
I want to add, because whenever we go over when to have huddles, there are certain people, or people will just hear and feel nervous that we're going to tell you you need to come together as a full team and huddle every hour or some ridiculous amount of time. That's not TeamBirth. What we want to have happen is anytime there's key decision points or there's a reason or a concern where maybe the nurse is calling the midwife or calling the physician, we want to make sure that those happen with the whole care team instead of playing telephone and having all these one-way conversations. So rest assured, you don't have to huddle every hour. That is definitely not a part of TeamBirth. And if you're not in the hospital, we do huddles over speakerphone, or you could even use some other technology device to support it. So you don't always have to stay in the hospital as well. Hopefully a few of you just exhaled and are feeling a little bit better. And Isaiah, carry on.
I do want to interrupt one more thing,
Okay.
Tim. Isaiah mentioned that huddles can occur at the request of any care team member, but it can actually be any team member, especially the patient or any of their support people. Yeah, they're the most important team members, so they can also request a huddle at any time. So just wanted to make that clear too.
Yeah, thank you for noting that, Barbara. Okay, so the planning board has 4 main components. So the team, preferences, the plan, and the next assessment. So the team is where you'll have information about the team members, and this would include names and roles and probably contact information for the nurse, the midwife, or the physician. The preferences section is where you would elicit preferences from the patient. And I'm sure that a lot of you will have patients coming in not knowing that they can have preferences and not knowing what the preferences could even be. So that preferences section is really a time where you'll want to engage in a discussion about what could their preferences be if they don't come in, having like a long list of what they do or don't want. So these could be light stim, quiet environment, no epidural, yes epidural, a variety of different things. So it's great to have a conversation with your entire team about that. And then the plan is where you would note the care plans for mom, the baby, and labor progress. This could be mom to use shower intermittently, labor progress can note will administer Pitocin if no change for X amount of time. So that sort of thing. And then under next assessment, you would document when the care team is going to huddle again so the patient knows when to expect a check-in. I will hand it over to Amber.
Thanks, Isaiah. So in addition to the team coming together and communicating slightly differently and maybe more structured, we also have some decision support guides. And these are really aimed at creating those shared decision-making opportunities with your patients around really key moments. So the one on the left is focused on admission. I know you can't really read these, the font's small. We're happy to follow up after the call and send you like a full-size version. But the one on the left is around admission. So really trying to decrease the amount of patients that are admitted to the hospital that are in early labor. The middle guide is around labor support and how what patients can really do at home versus what we can do with them in the hospital. And then the one on the far right is really a decision guide around whether you need to intervene for delivery. So thinking about C-sections, forceps delivery, or a vacuum delivery. Now, sorry for my calendar reminders. Both the admission and the delivery discussion guidelines should be familiar to you in the sense that they're ACOG SMFM guidelines. So there should be the care that you're already given, but they're written in patient-friendly language. So this can actually be discussion around the care team of whether or not we've reached the criteria to proceed with, for example, a cesarean birth. So again, we can follow up afterwards and make sure these are available to you guys. If you go to the next slide. So what you heard is that TeamBirth has a core, that's what we call it. The core means you have to do these things to say you're doing TeamBirth. And those core things are huddles, so the conversations with the care team, and using a shared planning board, which we will help you to create your own and make it pretty. But the add-on or sort of the additional things that we recommend are those decision aids. You can choose to use them. We do highly recommend it. In fact, I think all of our sites, except for maybe one, is currently using them across the United States. We add them as optional because some sites already have other forms or other documents they're using for that purpose. So if you don't have anything, definitely use them. But if you're already using a decision form for early admission, for example, you don't necessarily need to switch the one you're using. If you just do the core, so the huddles and the planning board, what you're going to see is you're going to see an elevation in patient dignity or patient experience. We see this very clearly in all of our research. We also hear about it from the site teams in their HCAP scores. So every hospital we've worked with has seen an improvement in their scores, especially around communication. You're going to mitigate implicit bias because instead of giving some care, like good communication to some people and bad communication to others, TeamBirth just makes it consistent so that every patient, every time, is getting the same quality of interaction and the same transparency. And then you're going to see an improvement in unit culture. So this does take time, as any kind of a culture change, but when you're having these conversations in front of the patient, caregivers are more accountable. They're going to talk in ways that are more respectful, to each other. And you're going to see just an improvement in your culture and transparency over time. If you add in those decision aids, most of our site teams do see that reduction in unnecessary C-section rates. And we've also seen improvements in severe maternal morbidity, as well as unexpected newborn complications. So both of those metrics, we've seen improvements for site teams that use these tools. So we will talk you through the decision-making process for those teams that are joining us on cohort 2. And you'll make it much more clear to you then, and especially since you can't read the tools in that small font. It'll be a future conversation, but wanted you to at least know there are these two separate components. Go ahead and go to the next slide. All right, TeamBirth Research. So back in actually 2016, 2017, we were partnering with your director, Barbara O'Brien, to design TeamBirth. And that collaboration extended to where we were able to do a pilot trial. And so you notice one of our pilot hospitals was located in the state of Oklahoma. So for 2 years, we did a pilot trial with these 4 hospitals, and we wanted to test, could people do this? Were people willing to have these type of conversations? And if we could get them to do it, would they like it? And as with any successful implementation, not only do patients have to like it, but providers need to like it as well. Otherwise, it's not going to be successful. And so if you go to the next slide, you will see some of our data here. And this data has been published, so you can access it in the journals, which are open access, and ISPEA will show you in just a second. But on the left, you can see our patients really liked TeamBirth. They had the desirable role they wanted in their birth experience. They felt they had really clear communication from the team, and they felt their preferences, sharing their preferences made a difference in the care that they received. So again, very, very positive metrics from the patients. And these are just a snapshot. We had many other very, very positive metrics. We were pleasantly surprised that clinicians liked it, because again, here we're telling them how to communicate differently, altering their workflows slightly. And to our really shock, we had very high acceptability, feasibility metrics from our clinicians. And clinicians, this includes nurses, midwives, and physicians. So you see that 93% of them felt it improved care for patients, 90% would recommend TeamBirth to other labor and delivery units, and 84% felt it helped them clarify non-urgent cesarean deliveries. So very, very positive results overall. And after ISPEA shows you and talks a bit about our manuscripts, I will show you some of our current data.
Yes, so we have 3 publications on the evidence of TeamBirth. And as Amber mentioned, they're all in the journal Birth, which are open access and available online. And you can also access these on ARIA, which is our online community of practice for TeamBirth, which I'll talk about bit later on. These publications really delve into the design of TeamBirth, the feasibility and acceptability, and then evidence on implementation from our qualitative data. So I will pass it back to Amber to go over data.
Okay, so I really love data. I wish we had more time to go into it, but I'm happy to answer any questions once we get towards the end. This is data we have from our current research. So this is from 2 of our hospitals that are in Oklahoma that we've been working really closely with over the past, I guess, year and a half now to implement TeamBirth and study its impact on really inequities of care by race and ethnicity. So what you're seeing here is a sample of the data. It's not the full data set because we just actually concluded data collection a few weeks ago. We will be publishing it, but this was our data as of January. What you can see here for these 2 hospitals, we have the metrics broken down by race and ethnicity. So we have these kind of 2 sets of bars. Each set of bar on the left are people who did not experience TeamBirth, and one on the right are people who did. And the scale that we're using here, you can see we have it shorthanded called MADAM2. What that means is it's a survey instrument called Mothers, Autonomy, and Decision Making. It was originally designed out of the University of British Columbia by a midwife researcher who's brilliant, and it has been well validated across the globe as well as also in the United States and in Canada. So that gives us a lot of ability to compare to other previous results. The reason we call it MADAM2 is because we actually want to know how a patient experiences their clinical team versus a singular provider. So basically it's shorthand for our internal data collection. So what we see here is the dark blue is high autonomy. So we want to see very dark blue. That means our patients are feeling like they have the ability to speak up, they feel respected, they feel really good about the choices made in their care. The dark orange is very, very low autonomy. We do not want to see that. And actually, if you read the questions, it's saddening to even know we have anybody in dark orange. These are people who go through feeling very disempowered by their care team. So let's start with the Hispanic group. On the left, we see 73% of those say they're Hispanic who did not have a TeamBirth huddle, say they had high autonomy. When they experience TeamBirth, you see that goes up to 94% of high autonomy. We see that similar pattern in non-Hispanic Black and African American. Non-Hispanic White, you see, starts at 58% and goes up to 88%, and then non-Hispanic multiracial 57% up to 89%. In both of the non-Hispanic multiracial and also the Black African American, you see that there's a complete elimination of that very low autonomy group. I do see that we have quite a few people on from Cherokee Nation, as well as the Indian Hospital in Claremore, is that correct? Yes. So in our larger full data sample, we are able to show Alaska Native Americans, but because this was a smaller data sample, we had to exclude it from the visual because we had low numbers. But in our manuscript and publication, you will see representation there. All right, let's move on to why now, why we are here working together in Oklahoma. So I'll hand it over to Barbara, and I'll talk to you again in a minute.
Thanks, Amber. So why are we doing this here in Oklahoma? And there's a lot of reasons, but first let's look at our C-section rates. When we look at the data, how our C-section rates in the United States, the top number is overall C-section rates, and the green is the NTSV C-section rate, or nulliparous term singleton vertex rate. So those you can see are both increasing over the last 15 years or so, you know, almost doubled for some of these. And it is concerning because these women who experience a C-section do have, we now know, higher rates of morbidity and mortality. So the key there is to eliminate especially those NTSV C-section rates. If you not eliminate but decrease them, they are then less likely to need a repeat C-section rate, which is the biggest generator for those, one of the larger contributors to that total C-section rate. If you look at the box, the text box at the bottom, you can see for the CDC final data statistics, this is for 2020, and Oklahoma had a total rate of 32.1, and that was higher than the US rate of 31.8. We were the 20th highest state in the United States. When we look at our NTSV C-section rate, we were lower in Oklahoma to the US rate. Our rate was 23.8, and 25.9 was the national rate. So we were actually in the bottom half, meaning we had a lower NTSV C-section rate, 21st lowest in the United States. When we look at the C-section rate, and we'll talk about that in another slide, what we do know that even though our state may have a lower rate than the United States for that NTSV C-section rate, it really comes down to unit culture in that hospital and whether how much that unit and the culture values supporting a vaginal birth, especially for those low-risk first-time moms. So we'll talk about that more in a moment, but I will tell you too, one of the pilot hospitals had their NTSV C-section rate decreased by more than 10 percentage points by participating in TeamBirth, by implementing TeamBirth. So what Amber mentioned, we do see that many hospitals will decrease that NTSV C-section rate, which we do anticipate will be publicly reported on Hospital Compare within the next couple of years. So looking at our next slide, we mentioned the variation among hospitals and how that has to do with unit cultures. So that is probably one of the driving forces behind the overuse of this procedure. C-sections are the #1 surgical procedure that is performed in the United States. And when we look at actions to reduce C-section rates, we need to pay attention by looking at data collection and the measurement of quality of care. Are you looking at your C-section rates in your hospital dashboards? using Medicaid policy to improve hospital management practices. We have seen some of that already in Oklahoma, but there could be more more could be done with the Medicaid policy, with creating audits and especially giving that feedback for physicians. And then enhancing that patient-centered decision-making through public reporting of C-section rates and outcomes. This is where I mentioned that it is likely to be reported on Hospital Compare. There was a webinar yesterday through CMS, and one of the things that Dr. Main from California reported, that they are now reporting on Yelp when a hospital, if someone is looking at hospitals on Yelp, their PCO2 C-section rate, or their low-risk cesarean delivery rate, is posted on their Yelp scores. So how can patients make decisions on where they choose to give birth? And then using these supportive birth professionals such as doulas, I will tell you there is work now being done to reimburse for doula care by Medicaid and private insurance rates. So hopefully that will come over the next year and a half. So that, we know nurses are very busy and may not be able to provide that continuous one-on-one support. So this can encourage the use of doulas in the care in our hospitals in Oklahoma. This has also been found to reduce C-section rates. Looking at the next slide, many of you all have participated in the Alliance for Innovation Maternal Health, our AIM work, and this has been done to implement maternal safety care bundles. There is a maternal safety care bundle about promoting vaginal birth. These data here you can see, since we began our work to implement the hemorrhage and hypertension protocols, we've seen a decrease in our SMM rate of 22%. You do see that go up in 2020. This is probably related to COVID. We know our maternal mortality rates. If we look at the next slide, in Oklahoma, we can see our maternal mortality rates. I say if you can go to the next slide. This is a 3-year rolling rate because our numbers are fairly low, so it's challenging to just show by 1 year, but you do see a decrease starting in that last time frame of 2017 to 2019. But we know in 2020 we did have 1 maternal death related to COVID, and I know in 2021 we had at least 8. So we likely, as Amber mentioned, will see these rates go up for 2021, 2021. But by decreasing our overall C-section rates and our MTSV C-section rates, this rate can also decrease. So looking at our next slide, I want to just highlight too the racial disparities in maternal mortality. And we know that it is 3 times more common for Black and Indigenous women than white women. In Oklahoma, we were ranked 38 for our maternal mortality outcomes. In, I believe this was 2017, 23 to 2017 data. And so we certainly have room for improvement in Oklahoma. And then on our next slide, I want to turn it over to Sarah Johnson, our patient partner for OPQIC.
Thanks, Barbara. As Barbara said, I am the patient partner for OPQIC. My work that I do here is to help convene a network of patient partners to inform the quality improvement projects that we do across the state. I had my own birth experience in 2016 that included lots of complications, and I left the hospital feeling very confused and traumatized. I still deal with PTSD to this day around my birth experience. And I can say from my perspective that TeamBirth would be a way to eliminate a lot of the questions I left the hospital with. It would have allowed communication to flow between the doctor and me in the same room, instead of that being the telephone system where I wasn't always sure exactly what the team was doing in order to help me. And also it would have allowed me to leave the hospital feeling empowered instead of feeling traumatized and confused. So we talk a lot about TeamBirth within our patient partner network, and here are a couple quotes that they have shared, they would like to share with the teams that are looking to implement this project. Including me and my family in communication during labor would have eliminated so many questions that I still have about what the team did or didn't do to help me. And I would have had confidence to ask for more testing, and maybe the multiple doctors working on my case would have worked more collaboratively with me and together to get an effective plan in place. I think many of us in the patient partner network experienced confusion with our teams whenever we had complications. There was oftentimes not consistent messages or consistent information being shared between the team members. So we definitely feel that TeamBirth could eliminate a lot of those issues that we experience. And we are just very excited to see all of you guys here today, that those of you that are interested in implementing TeamBirth. It's heartwarming to us. And the work that we do is so that we can really encourage you guys, the teams that are interested in TeamBirth, to take this project on, because we do see the benefit of it and impacting moms in Oklahoma. So thank you guys.
Thanks, Sarah. And I say if we go to the next slide, we've given you a lot of background information. So here is, what are we going to do here in Oklahoma? And how are we working with Oklahoma hospitals? So we mentioned our partnership with Ariadne. This is funded through the State Department of Health. They have received funding through the Maternal Child Health Bureau of the Health Resources and Services Administration. And this funding is supporting this initiative, which is a 3-year collaborative agreement to implement TeamBirth statewide in all 46 Oklahoma birthing hospitals. We have been working with our first cohort, and we'll share a little bit here about that. And you all would, if you agree to participate, would be participating in cohort 2. So I will turn it over to, I think.
I'm going to take over here, Barbara, just for a second.
So turn it over to Amber.
So we are going to get into more details in just a second around what this is going to look like for your team over the next several months. When would we be launching? What would the support look like, etc. But before we do that, I know we've been kind of talking at you and giving you a lot of information for a bit. So I wanted to just pause and answer any questions that you guys might have, or if there's any areas of confusion, to bring those up. So I'm actually going to go back through the list. And Jill, are you still on? Let me scan through. I know you have also been on several calls with us, so you may not have additional questions, but I wanted to just pause and see if there was anything that you wanted us to clarify before we move on.
Hi, this is Jill. I am on. Sorry, it took me a second to find my unmute button. But no, I really don't feel like I've had the advantage of having several meetings with you, and then was also able to meet with our system research specialist, with one of your specialists this week, to answer some further questions. So I feel like I will leave the rest of the questioning time to others.
Okay, great. Thanks, Jill. All right, how about April at Duncan Regional? Any questions from you, April?
Not really. I've tried to get some my new chief of OB to jump on today, but how do you get physician buy-in? Because he's not listening.
That's a really, really great question, April. And it's one of the bigger concerns that comes up with this project and actually with any kind of implementation project. So we do have a lot of strategies. One is that we have other physicians that are also willing to speak to your OBs if that's a voice they might be more willing to listen to. We'll make sure and provide you data so that you can speak to the evidence behind the project. And then ultimately, you still can implement and achieve success even without physician champions, because nurses can really lead this. And what we found is even for providers that resist, that over time, once they see TeamBirth and they kind of experience it and see the impact it makes to patients, that they will adopt that over time. So it's a good question, but it's not anything that we have not encountered before, and definitely something that we can help to overcome with you. And April, will you tell me, where is Duncan located?
We are about 2 hours south of Oklahoma City.
Okay, great. Thank you. We actually just came back from a trip to Oklahoma, so I'm getting my geography a little bit better across the state now. So thank you for sharing. How about from Ascension St. John, Jane Phillips? We have Stephanie and Dara.
Yeah, no, we're just interested in just hearing more information. I'll be interested to hear maybe as we have more discussion just about what this looks like in real time in the shift with some certain, situations and that kind of thing. That's one of the things that we've kind of talked about sitting here listening, but, otherwise it seems relatively, it makes sense. It seems relatively like an easy process. It's not a huge ask, I don't think so.
Yeah, and I think you're identifying going back to that original theme, we want this to be simple. So it is relatively simple. However, what it will do is it will change your unit culture, and that can take time. So it's not overly complicated to implement, and to train your staff, it's really things that they should be doing anyway. They should be communicating like this. It's just kind of bringing it all together and making it consistent, whether it's 2 p.m. or 2 a.m. But yeah, we'll go into more details too, Stephanie, around what it will look like and kind of to think through a timeline of how you would get this actually up and going at your facility. Stephanie, how closely do you work with St. John's in Tulsa? Do you guys work pretty closely as a system?
Yeah, we do. And you're getting ready to get to Amy too here in a second also, who's in Owasso and is our third hospital in the system. So I was in talks with Karen and Dana, just kind of asking them about what they were getting ready to roll out, or kind of what that was looking for them and what their teams look like. So yeah, we're in communication at least every month. We have a system-wide OB meeting just to catch up and then see what we've got going on. So anyhow, hopefully we will be able to ride on their coattails a little bit, and they can do some learning and pass on some helpful hints to us.
I think that will be successful. They launch next month, so we'll be back in April and get to celebrate their launch, and you will definitely get to learn from them. We found that to be really effective in all systems, but especially in Oklahoma. We just launched at the Hillcrest systems, and as you guys may or may not know, but Hillcrest was a site we started working with about 1.5 years ago. And so they were more quickly able to go from kind of the ideas of the project into getting it operationally set up, because they kind of had already system knowledge and system level support. So I think that will definitely benefit you all, and we do look forward to working with you. Okay, and you're right. You figured out my trick that I'm just going down the list. So now y'all know when you're going to be called on. Amy, how about you from St. John, Owasso?
So yeah, to kind of mirror Stephanie, I'm just kind of also wanting to see how all this rolls out with the main campus. And I also have some temps that work at some of the campuses that are starting to roll out next week. And so I'm excited to kind of also be able to hear more from them.
Good.
Just in talking and kind of bringing this up with my staff and kind of, get their involvement in it. Some of the questions they had were, We don't have a system right now to be able to call our physicians from the room, other than them using their personal cell phones. And so that's something that will be a question that we'll have to see if that's how we want to approach that when we're calling the patient from the room, because we don't have, you know, any type of system right now, or other hospitals do. And then again, you know, the whole physician, getting them on board. I've invited all of them to this webinar, but they're not on it. So we'll just kind of see, but I'm excited about, you know, hearing more.
Yeah, it's great to hear you again, and I'm glad you're able to join. Yeah, the phones, that is definitely something to solve for. Some of our hospitals, you know, that have more resources have actually put in requests to purchase phones for the nurses because they see them as being beneficial for multiple reasons. But other hospitals who don't have that kind of budget have actually just purchased phones in the patient's room that can do speaker, so that the patient can be involved in the conversation. So that might be a good solution for you all. And then, yes, we will definitely talk a lot about provider buy-in. And we know it's a real challenge. It's just something that we have worked with a lot, and we're not concerned about it as a team, because we have seen in every facility that we've worked in, see that get better over time and actually get their buy-in. But we know it's hard for you guys, especially all of you nurse leaders on the call. It's hard to work with that resistance, and we will support you, promise. Let me call, is Jasmine, are you on still?
Yeah, this is Dr. Baker. So I've actually been hearing about this since I was in residency in Oklahoma City at St. Anthony's, huddle, things like that. Yeah. So it's disheartening to hear that so many people are having issues with the physicians, because I feel like it is very much a team effort. So I mean, I'd be interested to hear what the nurses in our facility would say, but I feel like we have a pretty good collaborative team here already. But yeah.
And well, first of all, I'm really grateful that you're on the call, because it says a lot to your commitment for quality improvement and for patient-centered care. Just so I know, get it correct in my head, is it Jasmine Baker as a hyphenated last name, like Dr. Jasmine Baker, or is Jasmine your first name and Baker your last name?
Jasmine's first and Baker's last.
Yasmin. Okay, thank you for
Jasmine. And then I also have Dr. Dorsett here with me, who is the head of our OB department.
Oh, great. I'm glad you both are there. Yeah, and we really look forward to working with you guys. And yeah, I understand it's a little disheartening. I think where I try to go with it into like a more of a positive light is that healthcare is very, very demanding and challenging for everybody. And physicians are pulled in so many different directions that sometimes resistance is just the first reaction to, I don't want to do anything more. And when physicians do really hear about the project and actually get to see it or try it, there's much less resistance. And the message we hear often from people is, oh, this is how medicine should be. This is getting me able to return back to the bedside and have conversations with patients. Like, this is why I went into healthcare. So I hope that, you know, we'll see that with your same group of providers across your hospitals. But I'm really glad and thankful both of you and your colleague were able to join the call today. And Dr. Dorsett. Okay, great. Thank you for putting that in there. And I know you have Peachy, you're a midwife at Cherokee Nation, I believe. Yes. Any questions from you or thoughts?
Hey, I'm not Peachy. This is Melanie. I'm one of the midwives at Cherokee also. So I feel, honestly, after listening to you guys, I feel with Dr. Baker and Dr. Dorsett, we do maybe not everything, but we have a very good collaborative team. And as the midwives, we're in-house 24/7. So I can't speak 100% to everyone, but I feel like we do a very good job of shared decision-making, collaborative practice with both our patients, getting them involved in their decision-making, giving them their options, letting them know what the recommendations are and what their desires and wants are.
Yeah, that's well. And you are a midwife as well. And honestly, every time we talk to midwives, they say, we love TeamBirth because this is what we do. This is midwifery care. This is like very aligned. There are some nuances which are slightly different and will probably be pretty easy for you to adopt. So for example, you probably have those verbal conversations well, and you know, you're explaining options to patients, hearing about their preferences. but the actual visual of it being on the wall is a totally different component. Because as we know, patients, well, anybody who's been on an airplane and you reveal that you work in childbirth, you get to hear lots of birth stories. Now, how many times when you hear that birth story, do you think to yourself, there's no way that could have happened? Like, that does not make any sense. Or even Sarah saying, like, she didn't understand why everything happened or how it happened. There is a gap from what we say to patients and what they actually take in and understand. And so TeamBirth really does that closed loop communication by involving the patient in a more elevated role and keeping the plan, what's happening, very visual, so that even after that conversation's over, they can see it and know what is happening to them. But I'm really glad to hear that as a hospital or institution, you guys have so much commitment to the beliefs and foundations of the project, because it probably will make implementation more, a little bit easier for you all. Getting back up, Shelby, you're the director at Stillwater Medical Center.
Yes, I think right now we are excited and ready to take this on. We have a physician champion that is also very dedicated into doing whatever he can to improve our patient safety and outcomes. And I also feel like this will not only help the patient, but even our new staff, our brand new graduate nurses, to really maybe retain and understand the why behind many of our processes.
Yes, that is actually a huge bonus, because they hear the rationale much more clearly. And it's actually one of the things that when we were doing the pilot trial, we heard a lot about from the implementation leads, is the increase in critical thinking skills, especially to the new graduates. And just the communication being really clear, because we're all having the same conversation. We're not doing telephone. We're not me going in the hallway calling the provider and then me coming back in the room and talking to the patient. And there's a loss of translation that can occur there. So I'm glad you picked up on that, and really excited to be able to work with you.
This is Christine. I'm from Shawnee. So I guess my biggest concern is we're a rural facility that doesn't have physicians in-house all the time.
Yes.
And we have patients come in overnight. And so I can't imagine calling a physician at 10 o'clock at night to go over an induction admission.
Oh yeah, no problem. So
yeah,
we
like
definitely,
that, I guess just working through those processes would be a concern.
Yeah, we have a lot of experience working with small hospitals, community hospitals, and many of our sites do not have physicians or residents in-house all the time. It's not a problem. For your inductions, you wouldn't necessarily call and have a huddle because it was a planned admission. But if you had somebody show up in labor at 10 p.m., you would call and have a huddle with the patient and the provider, because you would need to call to get admission orders. So it's basically taking what you already have to do or need to do. It's just making the conversation happen with the patient instead of being all of that being separately communicated. Does that make sense?
Yeah.
Yeah, but we don't want to make it more complicated. Again, remember, this is meant to be simple. It's meant to be the minimum we need to have healthy functioning teams and good communication across. But we will work with all of you, because they'll be like, well, what about this circumstance? Or what about this? Our site is different in this way. And we will, you all will have time where we're working together as a collaborative, because it's really fun. One, you get to make new friends. You get to have shout outs from Amy. Maybe she's going to be the group cheerleader. And you get to learn from each other, which is really helpful. But we will also spend individual time with your hospitals with coaching calls, and those will happen on a monthly cadence. So this is where we can solve for the, what about at my institution, or what about with this particular provider? So you will have kind of both levels of support from our teams, as well as from the OPQIC team. Okay, and Lindsay from SWMC, no questions, looking forward to implementing. Okay, awesome. Thank you, Lindsay. All right, well, thank you for letting me put you on the spot. It's helpful to learn, hear your voices, learn your names, where you're from, and just hear kind of your thoughts. So I appreciate that. But let's dig into more now. What is this going to look like for your life over the next several months? So Isvea is going to walk through what our session sequence will look like in these kind of learning collaborative meetings, like the one that we're having right now.
Yes. So our first information sessions today, and then we'll have subsequent learning sessions, about 6 of them in May, June, July, August and September, where we'll be going through different components of implementing TeamBirth, and the kickoff webinar will be in May. So you will be receiving those invites that will be sent out by the OPQIC. And I'll pass it back to Amber for the timeline.
Yeah, so here is, actually, before we do the timeline, you can keep the slide up, but Barbara, will you or Denise, somebody from your team, share the times that those learning sessions will be? Because they're Wednesdays and Fridays, I believe, at a certain time.
Yes, I think we've decided for the first Tuesdays at 9 a.m. or the first Friday at 1:30 p.m. So like today's first Friday at 1:30, but we're going to have those sessions repeated and you can choose one or the other. So really we just want to offer two different options to make sure that you all have a choice and can make it to whatever session works most with your schedule.
Great, thank you, Denise. So Tuesdays and Fridays. I'm glad I asked you to share. Okay, so this is kind of what the timeline looks like. Now, most of these items can be a little bit flexible. So don't freak out if you look at this and be like, there's no way I can do that on that month. We can move things up or push them back depending on how it's going with you. And this is a contract, you know, with deliverables to the Department of Health. So we have to kind of keep on generally this timeline. But if we have another big COVID surge, you know, like we did with the first cohort, we will reevaluate and continue to support your teams and adapt as we need to. So where we're at now is kind of the first priority will be identifying a site PI, and that has to do with the research component, which I'll get more into in just a sec. It'll also incorporate building your implementation team. So it's not any one nurse or physician or midwife leader alone, but that you'll have a team around you, and we'll help describe that in our next session. And then also beginning the IRB process. So that's really the early things. So we don't necessarily need you to be talking to your staff yet or, you know, really socializing the project. It's just a few kind of operational components that need to be in place. By the time we get to June, we really need to be working on the board design. You know, we have a very kind of blank what a board should look like, but most sites want to work with their marketing team, add your colors, your fonts, you know, branding that's associated with your medical center. And that takes time to get all that approval. It also takes time to get them ordered. So that's why we want to get this done early in the project so that you have your boards printed, installed, and ready to go by the time you launch. We'll also work with you on developing the postpartum survey process. Like I said to you before, if we're doing an intervention to make care safer and more dignified to people giving birth, we need to hear from them around whether we're being successful or not. So there will be some amount of data collection. In the summer, we'll hopefully start surveying your teams, and then we will also start doing some small scale testing. So just like I think it was, oh, sorry, I'm forgetting your name. I think it was Carrie, something with the C, you just shared just a minute ago, was wondering what to do when providers weren't in-house. We'll need to have you do some small scale testing to make sure, oh, it's Christine, that's what it was, to make sure that you have all the kinks worked out before you go and train your whole staff. Towards the end of the summer, so depending how large your hospital is or small, you know, you may need only a couple weeks to train people. You might need 2 to 3 months. So that will take place over the summer and into September with a planned launch date of hopefully by the end of September, but we do realize some of you may need October, so I did put that onto the slide. So that is the kind of rough timing of what the activities and how they should take place over time. Feel free to put in any questions you have in the chat, but otherwise I'm going to move forward to talk about the research process. Okay, so we first and foremost, TeamBirth is a quality improvement project. We are implementing it across the state. So all 46 birthing hospitals will get the opportunity to implement. We are also doing secondarily some research, and I'll show you what our aims are in just a minute. The research is optional. If you cannot do the research, that is okay. We will still work with you, but you will still need to collect data that needs to be reported back to the Department of Health. So I'm going to talk about the research for a couple minutes so you have an understanding of what that will be, like what the difference would look like for your teams. Since I know some of you maybe have done research before, and some of you, this may be totally foreign and brand new, and that is totally okay. Our team takes on the majority of the responsibility. So we will do the heavy lifting, the paperwork processing, all of sort of the management of the research on our end. And you will be a contact, you will be responsible at your particular site, but you will have lots of support from us. So an IRB is this institutional review board. It basically is managing, monitoring, approving of any research activities to make sure that we're being ethical and we're protecting patients or subjects as much as possible. So we have an IRB at the Harvard School of Public Health, and we've already received approval for this study, and we will be enrolling your hospitals just like we had cohort 1 enrolled. We will be adding you to that protocol. Each hospital will need a site PI, with the exception, some of you that are in systems may be able to use a system PI. So that's, I know specifically for Ascension and also Integris, that you might have a slightly different pathway of having your systems on an IRB. But any of you else that are in systems, we should have that conversation. Somebody on your hospital team, though, needs to have human subject protection training. And that is in the form of something called CITI or through the NIH. And those are just like the brands of the training. It takes maybe 45 minutes to an hour, hour and a half if you read everything. And we will need that certificate of completion in order to add you to the IRB. And again, it's just a safety measure to make sure people are protecting patient data. What reliance means is that, like I said, we're going to file that original IRB with Harvard, and it's already been filed. And we will add you to the protocol and ask your facility to rely on us, or to seed review is another term that's used for that. And what that means is that we only have one IRB that we're all depending on, instead of having separate IRB reviews in all of your hospitals, which you can imagine just even as a paperwork standpoint is a mess. It's also required because this fund, the money for this grant comes from a federal grant, that we are required to do this reliance process on one IRB. Once these things are done, we've added you to the IRB, you have your human subjects training, and we have the reliance process done, then the research can begin. So how I just listed it out to you is overly simplistic because there's definitely lots of people involved. So we like to start this process soon to make sure we can get you enrolled and being okayed for research for us to collect baseline data. If you go to the next slide, this is kind of saying the same thing, but I kept this slide in here because it has some pictures and a little bit more information, so you can use it to look back on, or if you want to read a little bit more carefully. But let's go to the next slide. For reliance, there are two pathways. There's one pathway called Smart IRB, and this is a system your hospital can sign up for. And basically what that means is anytime we have a change to our IRB, let's say I hire a new research assistant and I add her onto the IRB. If you're on Smart IRB with us through your reliance, it's all done automatically. You don't have to do anything. The other option is to do this IAA form, and it's basically the same reliance process. It's just on a form, like through paperwork. The main difference is it's available to everybody. So if you don't have Smart IRB, don't worry, we can do this IAA form. And if we make any changes on our IRB, we will need to send you the information so that you can also have record of it at your institution. So both are totally fine. In cohort 1, we have gone both options. So no matter what your hospital prefers to use, we're happy to accommodate. And we do have a reliance specialist who works with our team at Harvard that will be happy to meet with you or any of your people from your hospital to make sure that this process is as straightforward and simple as possible. Okay, so that is about the research process. If you go to the next slide, these are our research aims. So I know it's kind of written in like research language, but basically we want to know two things. The first, we want to know if by doing TeamBirth and having these transparent conversations with your provider and your nursing staff, does that increase your trust in the institution, or trust in your care team, I guess is actually the better way to say it. Since we know that a lot of patients don't actually trust their providers, or especially they feel that they've been marginalized by the healthcare system in general, and that trust is a really, really important component for safe care. So we want to look at, does that type of communication improve trust? The other thing we want to look at is we want to look at continuing to study this mother's autonomy and decision making. We have seen, obviously I showed you that data, we've seen big improvements in autonomy scores, but we want to continue to look at that across the state in a much larger sample. We also have a few additional questions we want to look at individually, and then all of these variables we want to look at by race, ethnicity. Since we talked to you earlier about how so much of our outcomes and our experience in childbirth is really, well, actually, let me say that differently. We know there are really, really big inequities in care. We know that both in the outcomes and also in the experience. And we want to try to reduce some of those inequities and disparities. And so needing to understand more about where they are and how patients are perceiving their care. So those are our research aims. Additionally, with the research, if you are participating with us in that capacity, you will receive data feedback reports in an ongoing basis. What that will do for you is you will have some ability to track how many patients are saying they had TeamBirth huddles, how many patients are saying they used the board, things like that. But you'll also have an ability to track over time looking at both of these survey tools or these metrics. And so it helps to really inform your implementation team on where you need to, maybe potentially do more education, or where you need to help kind of coach your teams. So the data, although if you've not done research, it might feel overwhelming or foreign to all the site teams that we're working with now. It's one of their favorite parts because they get to really hear from patients, and it really encourages them into what they're doing. So that kind of covers the research. Again, happy to answer any questions, and also is something that we'll talk much more about. Let's go to the next slide, because I want to just pull back and kind of describe the larger movement that's happening with TeamBirth and the part you guys play in it. So really looking, this is kind of a history and a timeline, which I talked you through earlier today, but looking at where we're at for 2022, we are partnering with more and more organizations that are implementing TeamBirth. And so we went from just a few hospitals to now spreading throughout, I think we're up to 40 plus now hospitals that will be launching this year in 2022. We are also in conversations daily, weekly with other people wanting to implement. We just spoke with Illinois that's looking at rolling it out with 20 some of their hospitals in the next couple of years. And we're also talking with partners overseas who are wanting to do TeamBirth in the UK as well as in other countries. So the demand for this type of solution is really, really increasing. If you go to the next slide, and I will get to some of your, Barbara answered it. Great, thanks, Jill. Doesn't have to be a physician. We have a lot of nurse leaders that are PIs at our sites, and we love getting nurses involved in research. They don't always have the same opportunities. So it can be anyone, as long as your hospital is okaying them to be a PI. So here's where we're at for just currently in 2022. These are the hospitals that are implementing or have implemented. You can see there's a large contingency from the West Coast. We are working with the Providence Health System to implement. Michigan is implementing across their state. We're implementing just starting actually in New Jersey with several of their sites as a part of the Department of Health project. And then Ohio, several sites as a part of work with March of Dimes. And actually we need to add Tennessee, because there's a few hospitals from Tennessee that have joined as well. So you can see the demand is growing. It's awesome that we get to work with you guys on this project. And the uniqueness that Oklahoma has that nobody else has across these projects is that you get a lot of our time. You get really close, really technical assistance, coaching, hand-holding, if you want to say it, that moral support, free counseling. whatever you want to call it, we have a unique relationship with you all and a partnership with the Oklahoma Perinatal Improvement Collaborative, where we get to give you more concentrated support. So if this feels overwhelming or you're not sure what it's going to look like for your team, do keep that in mind, that you will have a lot of support, whatever the support you need to be successful in the project. So will your hospital be added to the list? I hope all of your hospitals are, because we definitely believe that you can do it, and we look forward to working with you. And let's go to the next slide. Barbara, do you want to share this? I feel like my voice has been monologuing for a long time and everyone might need a break from me.
Sure. Yeah, we are so excited because just this week, beginning Monday evening and through Wednesday, we launched TeamBirth at 4 of our hospitals that are in cohort 1. So you can see their pictures here. We like to celebrate an official kind of launch. You may actually begin doing TeamBirth a little bit before this, but just to have a time where you gather and recognize your team, your implementation team, and all of your champions and staff for the hard work that you've done. Our 4 hospitals did a great job. The first one down in the bottom left corner, St. Mary's Regional in Enid, and then we went up to Hillcrest on the top left, Hillcrest South in Tulsa, and then over to the right, top Bailey Medical Center in Owasso, and down at the bottom right, Hillcrest Claremore in Claremore, Oklahoma. And the rest of our cohort 1 hospitals will be launching in April. So this is just a really fun time, and we were so impressed with all the work that the teams have done to put this into place. So just a really exciting time for all of us, and a time for yay. This was for a lot of us. We got to actually see each other in person. So that was great, and we are just so excited and really excited to be doing this statewide in Oklahoma.
And you're up for the next slide as well. Whether somebody from your team, Barbara.
I guess I can go ahead. Next up, or Denise, I saw you come on. You feel free to do this next slide.
Okay, sure. So our next steps is what we're going to kind of go over for what you can anticipate. The first thing that we want you to focus on is getting the hospital commitment letter signed. And I'll drop a link to that in the chat if you don't already have a copy of the letter. But that is a signature from a nurse implementation leader, an administrative leader, and then a physician leader within your facility. We would appreciate if you can have that submitted back to us by April 22nd. We are also going to ask you to complete a hospital registration form. Just gives us a little bit of background and some demographics about your unit. We want you to start looking at identifying and recruiting your team members, and that's going to be the champions that you're going to ask to kind of get the motivation and the word out and socializing this among your team. Again, identifying the IRB contacts and beginning the reliance process. And that's something that we've realized can be time consuming and take a lot of time and duration in getting the right kinds of signatures. So we want to kind of begin that as soon as possible. And then when it starts to coming time to doing our learning sessions, and we're going to kick off our first learning session with a planning kickoff in May. And again, we're going to have those on the first Tuesdays and the first Fridays. So that would be either May 3rd or May 6th. And you can see a registration link there, and we'll also get that dropped into the chat. And then we'll continue our monthly learning sessions until the launch time from May to October, monthly sessions during that time. In between our learning sessions, we will be having monthly coaching calls with each of your facilities, and we'll talk more in detail and get those arranged later, but just kind of what to expect as we go forward with implementation.
And I will add, so these learning sessions are the time that you can all work together. All of the hospitals attend and learn from each other. And then the coaching calls are the individual hospital calls. So there's basically 2 monthly times that you would be meeting with us.
One thing that we've appreciated with this initiative, and especially with the support of the Ariadne team, is that we are able to kind of follow up with you frequently, and we will give you monthly emails with a checklist of everything that you're supposed to, focus on for that month, links to all of the documents and things that you need. So you will be getting a lot of communication from us in that regard.
Yes, and to piggyback on that point, ARIA is our online community of practice for TeamBirth. So this is where you'll find all of the materials that you'll need for implementing TeamBirth. We also have our publications up on ARIA that you can access via the ARIA website. We also have some new TeamBirth training videos that we actually filmed in Oklahoma. So those are really helpful. We have about, I think, 7 of them, and they're about 5 to 10 minutes in length. So those can also be accessed via ARIA. There is additionally a forum where you can connect with people nationally who are implementing TeamBirth. So ARIA is going to be a great resource for you as you start to implement TeamBirth at your sites. And we'll send a link to ARIA as well in a follow-up.
And we can go, actually, let's go ahead and stop sharing slides because we only have a couple minutes. I wanted to make sure with those that are still on the call, if there's any additional questions that come up around the hospital commitment letter, the IRB, the research, the project, anything, please do come off mute and speak up, or you're more than welcome to reach out to us by email as well.
Do you know about how long each quarter, or however the information was submitted, how much time it took as far as a commitment, like to do their actual research and get the data and all of that kind of stuff?
Oh, like how many months it took,
well,
or hours it took?
How many hours it took? Because I have to.
Yeah, it's not a lot for your team. It's much more for my team, and really what the barrier or the challenge is that it takes time, as in weeks, and processing and just getting communication back and forth. It doesn't take actually many hours from you. So yeah, it's just kind of a slow process. I think anytime you're working through a massive organization with another large organization, it's not exactly speedy, but it shouldn't take, you should plan, I don't know, 15 minutes a week, maybe, that you might have to check in on the process, or you might have to email somebody internally or give us a name of a contact. It should be pretty minimal.
Okay.
I do want to clarify, there is a component if you're doing paper surveys. We'll go more into depth where your, when we get to that point where your team member can enter the responses for that surveys into the Qualtrics system, but not all of your patients are going to complete a survey, and we usually have a response rate of about 40 to 50%. And then this doesn't have to be, this can be anyone from your team that enters that data. And when we talk more about it, you'll hear that hospitals that use these data and the ones who enter it really think of this as a highlight of their job, because they get to see all of this positive data and the positive comments that the patients leave, and they're able to share those comments with the team. So it's a big morale booster to do and to hear, to share with your team. So I do want to mention, I don't know, Christy, which component you were asking about, but there is a piece of that as well.
Right. Yeah, I'm just trying to figure out time commitment, and if I have to recruit people and productivity hours and all the things that we do with budgeting, all that kind of stuff. Okay.
Again, I know I said it before, but we are really excited to start working with your hospitals, and we'll look forward to launching with you as well in the fall. We'll send up some materials as a follow-up to this meeting, so you'll get an email from us. But if there's anything that comes to your mind between now and when we are able to meet again, please do reach out and email us, because we're happy to answer any questions ahead of the next meeting.